Hello, this is Dr. A with a clinical chemistry review on your adrenal cortex hormones. Okay, so let's first talk about the adrenal glands. The adrenal glands produce steroid hormones and neuropeptides that are essential for life. They are a pyramid-shaped organ that are located just above and medial to the kidneys. So they look like little hats sitting on top of kidneys. You have one on top of each of your kidney. The arterial supply is symmetric to each of them, and there are also axons that reach the medulla through the cortex, and so that is important. So part of your adrenal glands are linked into your sympathetic nervous system. The adrenal cortex itself is divided into three zones. There's the zona glomerulosa, or G-zone cells, and they're the outer 10%, so we're going from outside in. These cells synthesize mineralocorticoids that are critical for sodium retention, potassium, and acid-base homeostasis. An example of those would be aldosterone. The next layer in is the zona fasciculata, or the F-zone cells. They're the middle 75%, so that's a bigger chunk, right? It's a thicker layer. And they synthesize your glucocorticoids that are critical to blood glucose homeostasis and blood pressure, so we're thinking of that, or cortisol hormone. And then you have the zona reticularis, which is the R-zone cells, which is the inner 10% layer of the cortex. And these produce hormones such as sulfate DHEA and DHEAS, which are some of your androgens. So let's talk a little bit about cortex steroidogenesis. So the hormones that the adrenal cortex produces are steroids, or variants of steroids, and so therefore they are all made by the sequential enzymatic conversion of the common substrate cholesterol. So you need cholesterol to build all of these hormones. So cholesterol is quite an important molecule for that. Only free cholesterol can enter steroidogenic pathways, and it does so in response to the ACTH, or adenocorticotropic hormone. The conversion of cholesterol to pregnenolone is a rate-limiting step in steroid biosynthesis. So basically, you can only produce as much steroid-type hormones as you can produce pregnenolone, right? So as long as you can convert cholesterol to pregnenolone, then from pregnenolone, you can produce a lot of the other hormones, a lot of the other steroids. A decreased activity of any of the enzymes in these pathways can occur as an acquired or an inherited trait, so you can have problems manufacturing some of these steroid hormones. An evaluation of adrenal function will require measuring obviously the relevant adrenal hormones, their metabolites, but also their regulatory secretagogues, which means you'd have to go up and down the cascade. So you might, if you're investigating, for example, cortisol, you may have to measure cortisol, but also ACTH or CRH, which is is corticotropin releasing hormone. This gives you an appreciation of what's going on with this steroidogenesis. So we start these pathways. We start here with cholesterol, the common precursor. And this is a rate-limiting step. It has to convert to pregnenolone. So that is the first step. So you have to be able to make pregnenolone. Once you make pregnenolone, there's different pathways. So you could go, for example, here to progesterone, and then we can go 17A hydroxyprogesterone to androstenedione, testosterone, and dihydrotestosterone. So, and then from testosterone, you can cross over to estradiol, which is the most common estrogen, estrone, estriol. Here are your estrogens. So here are your androgens here. And so again, from progesterone, pregnenolone and progesterone, there's different, you can go down this pathway here and make testosterone, but you can also go this way, or you can go that way. There's different pathways to make testosterone, and requiring different of these enzymes here. The enzymes that are in green are located in the smooth endoplasmic reticulum of the cell, and these three, orangey red ones are located in the mitochondria. So this is interesting here. So that means that you have to have good mitochondrial function to go from cholesterol to pregnenolone. And then from here, so for example, you go pregnenolone, progesterone, and then we have the oxycorticosterone, and then you can have aldosterone here, or they can go 17-hydroxyprogesterone and 11-dehydrocortisol and make cortisol. So you have glucocorticoids here and mineralocorticoids. So again, quite complex pathways here. And in some of it, for example, just on the side note, if you're under a lot of stress, you will be converting a lot of your pregnenolone towards these pathways to make cortisol, which will take them away from the pathways to make testosterone or estradiol and all that. And so stress can interfere, for example, with fertility because of that. All right, so let's talk about some abnormalities. We have congenital adrenal hyperplasia. So it's an inherited family of enzyme disorders that causes decreased cortisol and aldosterone production. So if you go back here, there's this group right here, the production is decreased. Normally, the G cells convert cholesterol to pregnenolone and then into aldosterone, and then aldosterone will act on the kidneys to increase vascular fluid volume and just increase blood pressure. So aldosterone allows you to conserve water and pull it from the filtrate that's going to become urine and put it back into your circulation. And it does that by moving potassium and dumping, moving sodium and dumping potassium. Sorry about that. Anyway, hyperaldosteronism then can lead to high blood pressure and low potassium values and also probably high sodium values because it'll keep pulling, if you make too much aldosterone, it'll keep pulling the sodium, water follows the sodium and dump potassium in exchange. And so high blood pressure with low potassium, you should suspect hyperaldosteronism. You can have isolated hypoaldosteronism, so not making enough, and that could be caused by adrenal gland destruction, chronic heparin therapy, unilateral adrenalectomy, and G-layer enzyme deficiencies. If you don't have enough aldosterone, then you'll tend to have, I guess, lower blood pressure and be more fluid deficient and stuff, and not you don't have that ability to balance do the water balance as well. Cortisol synthesis is critical to hemodynamic and glucose homeostasis, and that would be affected, of course, because you would have decreased cortisol production in congenital adrenal hyperplasia. So congenital adrenal hyperplasia, there are 3 criteria to diagnose this disorder. One, you want to get plasma aldosterone to plasma renin and look at the ratio between the two. So the aldosterone to renin activity is greater than 25. That would indicate congenital adrenal hyperplasia. If you have low plasma renin that fails to increase with volume depletion is an indication. And if you have high aldosterone that fails to decrease with saline or angiotensin inhibition, should also suspect congenital adrenal hyperplasia. So the test that you run, obviously, to assess that would be, you need to check the urinary potassium excretion, the upright PA to PRA ratio, so the aldosterone to renin activity ratio, captopril suppression, 18-hydroxycorticosterone levels, adrenal imaging, and adrenal vein sampling. Adrenal insufficiency, also known as Addison's disease. The cause can be a primary adrenal problem, so the adrenal glands are not functioning, or it could be an ACTH deficiency, so that would be at the level of the pituitary. The symptoms are going to be weakness, fatigue, anorexia, nausea, diarrhea, abdominal pain, and weight loss. And so this could be like some, if you will, some form of extreme adrenal fatigue. The diagnosis, you would have low baseline cortisol levels. Cortisol is really what give you energy in the morning and stuff, and energy throughout the day. So if you have low baseline cortisol levels, then you don't have any energy. And an ACTH greater than 200 picograms per mil, meaning your pituitary is trying to stimulate your adrenal glands, is producing a lot of ACTH to try to get those cortisol levels up, but your adrenal glands is simply not responding to it. The treatment is going to be synthetic steroids from the G and R zones are replaced, so it would be your mineralocorticoids and DHEA. A little bit on the HPA axis. It coordinates the actions of the neuroendocrine system. So HPA is hypothalamus pituitary adrenal. So stress and other type of metabolism here to deal with. So what happens is, so the hypothalamus will produce CRH, or corticotropin releasing hormone, which goes to the anterior pituitary. And then the anterior pituitary, in response to CRH, will release ACTH, or adenocorticotropic hormone, and it will travel over to the adrenal cortex and have the adrenal cortex produce and release cortisol. And then once cortisol is in the bloodstream, it gives a negative feedback to the pituitary, and the hypothalamus says, okay, we got the cortisol up, we can turn off CRH and ACTH. And so the HPA axis is meant to control reactions to stress, but it can also regulate digestion, the immune system, mood, sexuality, and energy storage and expenditure. And for example, if you have a lot of stress going on, like digestion is not going to happen as well. The immune system is not going to be as good fighting off infections and stuff. You'll be in a bad mood. Sexuality, that you're going to have problems. If you're a male, you may have erectile dysfunction. You just are not interested. That kind of stuff. And it can energy storage and expenditure. Too much cortisol it will end up making you gain weight. And then, so hypercortisolism and Cushing's disease. So this is high cortisol levels. So hypercortisolism can be caused by the overproduction of CRH or ACTH, and by adrenal corticoid secretion. So too much of any of them up and down the HPA axis, but also exogenous intake. So if you take steroids, that could lead to Cushing's. Cushing's syndrome is caused by excess glucocorticoid production or prolonged exogenous steroid use. And sometimes that happens as a side effect of treatment for something else. Glucocorticoids like cortisone are often used to treat inflammatory conditions. The signs and symptoms of Cushing's and hypercortisolism are obesity in the torso, so central obesity, so around the abdomen, torso area, with thinner arms and legs, a moon face or a round fat face, increased fat in the neck and shoulder area, which is called a buffalo hump, thirst and excessive urination, visual problems that are caused by glaucoma or cataracts, and an increased susceptibility to infections, and then also thin, fragile skin that bruises easily and heals slowly. And there are many, many more, but these are some of the predominant ones. For diagnosis, you need to determine if it's ACTH dependent versus ACTH independent hypercortisolism. You can do a two-side ARMA assay for ACTH. You also need to do pituitary versus ectopic ACTH secretion via a high-dose dexamethasone suppression test. So an ectopic ACTH could be a tumor that's producing, for example, ACTH, versus the pituitary actually producing it. 60 to 70% of patients with non-suppressible ACTH secretion to high-dose dexamethasone therapy will have Cushing's disease. So if you cannot suppress ACTH, then they have Cushing's. Imaging with CT or MRI is used to localize pituitary or ectopic ACTH secreting tumors. So you want to, for diagnosis, you need to document cortisol excess. So for that, you can do a urine-free cortisol and or metabolites. There's also a way to do salivary cortisol, by the way. And you can do random plasma cortisol levels, but it's you need to note the time of when it's drawn, or you can also do baseline morning cortisol concentration. So it is good to do also like morning and evening cortisol level to see if the diurnal rhythm is lost. So normally what happens in your daytime is your cortisol levels are climbed during the morning and are probably highest mid-morning going into lunchtime, and that gives you your activity to start your day. And then after lunchtime or so, they start dropping steadily, and it will drop steadily until evening, so your energy levels drop, and then there will be the lowest at the time when you go to bed, and then overnight you start rebuilding, rebuilding it, and then they should start rising again in the morning. So if your late night values remain high, then you could have hypercortisolism, because it normally should be dropping. And so you can determine the loss of normal cortisol suppression again by dexamethasone injection. So you can also do a CRH stimulation test to determine the ACTH dependency. It distinguishes the type of disease, central versus primary adrenal. So is the problem in the pituitary or hypothalamus, or is the problem in the adrenal glands? If CRH is injected, and then cortisol and ACTH levels are measured to see how they respond to the CRH injection. And how to localize it, how to find where the problem is. For adrenal Cushing's, you need an adrenal CT to look for tumors or hyperplasia, and an adrenal MRI T2 weighted image to see about to discern carcinoma. For pituitary Cushing's, you need a pituitary MRI, and for ectopic Cushing's, you need to do a chest CT to see where that tumor might be. The treatment for all types is going to be surgery, radiation, and or medication to suppress the adrenal cortisol production. For androgen excess, the symptoms in boys are penile enlargement, hair growth, and precocious puberty. In girls, it's going to be ambiguous genitalia in infants, hirsutism, acne, clitoromegaly, short stature, and precocious puberty. And in women, it would be, if you have too much androgens, you will have infertility, hirsutism, which is like hair on the face and stuff, acne, male pattern baldness, and menstrual irregularities and virility. So like having like male-like features. And in men, you can have infertility and decreases in the following, which would be muscle mass, hair growth, testes size, testosterone production, and spermatogenesis. The diagnosis for androgen excess is going to be high levels of DHEAS or DHEA or testosterone. And the treatment could be surgical removal of tumors if they're present. And then you need to also obviously see if the patient is taking exogenous DHEA, because it is a supplement that is available. And obviously consider stopping supplementation if that's the case. And that is the last of the presentation. Thank you.